The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone, welcome and thanks for joining. I just have a couple housekeeping items before we get started. The first is that we are recording this and we will send the recording to you tomorrow. The second is that this is part of a series. So Sean, if you could just cycle to the next slide, please. Yep, so if you want to view any of the past webinars that we had or sign up for the following one, you can just visit the URL at the bottom of your screen. Finally, we encourage questions. We'll make sure that we get to any questions that the audience has during the panel discussion at the end. So if you have any, just drop them in the question area in the GoToWebinar module. So we're going to hear from Sean, who's going to tell us about the iTether solution that he's built. And then afterwards, we're just going to have a panel discussion with Jaku, who is the VP of Product at Kinvey, and Joe, who's a product manager at Google Cloud Platform. So with that, I'll just turn it over to you, Sean.
All right, good morning, and thank you all for jumping on for this today. We're going to talk a little bit about our solution. Start out with talking about the problem that we're trying to provide a solution to, give some background on that, and then talk a little bit about the solution and how we arrived at where we are. So we'll talk a little bit about addiction or substance use disorder. In 2014, we had over 100,000 people that died as a result of their addiction. I'm sure all of you know that by following the news that we have, we're still on the left-hand side of the bell curve for the opioid crisis that's taking over the country. 2.5 million people on any given day were in addiction treatment, received addiction treatment. Another 23 million needed addiction treatment, and this is according to SAMHSA, the Substance Abuse and Mental Health Services Administration. The 2.5 million, that treatment cost $35 billion, and then the total cost of the U.S. economy for addiction is $700 billion annually, and that's the cost for health care, lost work productivity, law enforcement, etc. It's a pretty staggering number. Let's say, talk a little bit about addiction. And addiction does not discriminate. It reaches all classes, social, ethnic, race, etc. And for every one person that is suffering from addiction, it impacts about 10 people around them. So it's a significant issue in the U.S. today. Talk about where we are today. In addiction recovery for the treatment planning, it's basically been delivered the same way for about 40 years. It's pretty much paper-based and one size fits all. When someone goes through an inpatient program for 30 days, that can cost anywhere from $10,000 to $100,000 depending on what level of facility you're in. There's a 90% probability that the patient will relapse if they do nothing else beyond that 30-day period. And it just makes sense. With any other diseases like diabetes, you don't give someone insulin for 30 days and say you're good to go. Obviously, the longer someone's in treatment, the higher the probability of success. And it is proved out here where individuals that go through what's called intensive outpatient, where they start integrating back into life and work again, but continue some form of treatment, they have a 50% probability, so there's a direct correlation there. Talk a little bit about the market mandates. With the passage of the Affordable Care Act, successful evidence-based treatments will be rewarded. Today, and the way it's been done traditionally, it's a fee for service or a head count. If you treated someone, you get paid. We haven't traditionally looked at what works and what doesn't work across demographics, across populations. It's basically fee for service, and that is changing. In fact, by 2018, in all across healthcare, we're seeing those changes. So it's really a great opportunity to, we see that as an opportunity to help raise the standards. With the 10% success rate, we want to see that increase. We want to actively engage patients with technology and reach them outside of the clinic so we can deliver accountability by enabling evidence-based outcomes and improving long-term recovery rates. That's our mission. Talk a little bit about our platform. We took a little bit different approach. There's a lot of apps out there that provide goal setting and various things that help an individual if they're self-motivated. But we've taken a different approach where we're taking the patient, delivering the treatment curriculum, courses, goal setting, interactive videos, choice of learning, and individualized content that's provided by the provider. And for the provider, they have the ability to give individualized care through audio, video, and digital. They take their curriculum, we help them convert it to our platform where they can deliver it out to the patient. So now you've changed that dynamic from paper-based to digital media, and now you can start tracking based on demographic, drug of choice, what patient received information, and then look at the outcomes. How successful was this training for this individual, and then of course across populations. So it really allows providers to enhance and customize their treatment programs to meet the needs of the individuals. And then for the payer, which is insurance companies and Medicare, they're switching over to value-based care, value-based payments, and now they can see which providers' programs are working with across populations and across their patient base, and now they know what they're paying for and can direct patients to individual providers that have a better success rate. So it's going to drive up the level, we believe, the level of recovery, because we're going to start seeing what works and what doesn't work in really the simplest terms, and we touch across the continuum of care. What we put together is a behavior change platform, and that is something we put together with Kinvey and Google. It resides in the cloud, and we allow the provider through their portal to load the digital curriculum, goals, communication and intervention strategies, zones and triggers for geofencing, assessments to see where patients are at in terms of their recovery, gamification. We're building groups and social groups, and of course analytics, and we provide this for both the provider and the payer. And then reaching across, we deliver treatment plan to the patient, so this extends care beyond the clinic, and that's one of the big game changers here. Is traditionally we had someone in for 30 days and then they're out and may or may not get counseling. Now we can extend care into intensive outpatient and beyond into what we call aftercare, which can go 12 to 24 months, and it's substantially less expensive than having someone sit in a 30-day, and it keeps them connected to their provider, so they're connected to their program, and that's what works. And then we'll take that even further using Google BigQuery and start looking at the data around behavior, Internet of Things, where we have biometric feedback, breathalyzers, and start really looking at this from a population standpoint and determining what works and what doesn't work. And that's the real value in having this data available. When we first started looking at this, we actually went through a couple of development firms before we got where we are today, but we had a system that we do it ourselves app on AWS, and it was just it was going to take too much money and too much time. We wanted to get out to market quicker and prove the concept. So it was going to cost us over $1 million, heavy business investment, and we didn't have the connectivity to some of the electronic health record systems that we need right out of the gate. Also, we're wanted to be HIPAA compliant, and then of course the maintenance issue. We're going to have to become experts in maintaining this as well. And really our focus, where the actual app development work, is really where we wanted to put our focus, not on hosting and running this system. So where we ended up is kind of putting that on the back burner, and went and signed on with Kinvey and Google, because then we were instantly on. We basically had this concept. We wanted to get to market quickly. We want to test our concepts and iterate based on the feedback from the marketplace. So that's where we are today, where we stood this thing up for a fraction of the cost. We're already out to beta testing and pilot testing. We're HIPAA compliant out of the box, and infrastructure and DevOps are included. So we're a very lean organization. It's a lean business model. We're counting on our partners to help provide that part and be the experts in the platform side. So that's really worked out well for us. Talk a little bit more about how the platform really allows us to deliver communication and collaboration and create an integrated environment. So inside the circle here, you see the gears represent the rules-based engine. The subject matter experts are behavioral change specialists, load their rules, their goals, their content onto our platform and through the portal, and then of course we deliver analytics. So we've designed this and built this to be extensible as the market changes, as new functionality is required, we can plug it in. We're starting out with what we call our minimal viable product, and that includes calendaring or event-driven. You must show up for a meeting, you must complete this task at this location, and we can validate the GPS location, and they can check in. So we have that kind of accountability and confirmation through calendaring and event-driven. And then we have the curriculum, which I've mentioned that we deliver in a blended environment for both in classroom and out of classroom, so it extends the clinic beyond. And we also provide substantial measuring for value of content to individuals and populations. And then goal setting, goals are tied, very specific goals, to the curriculum, calendaring, and the treatment plan. And again, it's another measurement tool for the providers that they can see how effective their goal setting is to their treatment plan. And then we can extend this with biometric sensors. In 2012, MIT did a study around opiate addicts and developed an algorithm that determined that the rate of heart rate acceleration was a determinant of relapse, and then they could provide intervention via smartphone. And that's exactly what we are planning to do with sensors, is be able to give that feedback to allow people to learn that their anxiety or their feelings are coming about, and the interventions that they can do to prevent a relapse. And then of course we can do the blood alcohol sensors and those types of devices that are used as an enforcement tool where needed. And then we can also integrate electronic health records, social networking, gamification. So our platform allows us to plug in different functional areas and then draw analytics around these functional data points. We can also plug in, we've been asked to plug in employment functionality, housing, and eventually virtual reality as part of treatment. So it's all part of this extensible platform that we've built to grow as the market becomes educated and we can provide technology-assisted care. And from passion comes progress. We're very passionate about this, and we're not doing this alone. We have several partners in both on the payer side, the provider side, and the technology side with Kinvey, Google, and Tiempo as well. We're also partnering with the Arizona State University and doing some trials around the efficacy of different types of content with different populations. So it's really kind of changed. We hope to really dynamically change, transform the way that addiction recovery and behavioral health is delivered and managed, and we believe that the patients are going to benefit immensely. So we'll go ahead and move on to our panel discussion. I kind of moved through that pretty quickly. If there are any questions we can get started with, and if any audience questions as well.
All right. This is Jaku Venkat from Kinvey. So Sean, it was a great presentation. Thank you very much. You mentioned that you expect that this is costing a lot of money. You know, I think the number was like $35 billion or so. And how much do you really expect of this will be saved using an approach like this, a solution like this? What do you expect the savings to be for an health insurance company or a payer?
Well, I'll kind of give you a business case that we see, unfortunately, quite often today. Over a span of a year or two, an individual will go into inpatient treatment, and let's just, it's anywhere from $10,000 to $100,000, but let's just say $30,000 when they go in through their inpatient treatment, and then oftentimes within 6 months to a year, they're back in again if they haven't continued some form of treatment, and there's a 90% failure rate at this point in that area. So where we see this as a real value add both for providers and especially for payers is that it allows the providers to extend their care and include, they are now adding additional services where they're keeping their patients, their clients connected outside of the clinical environment at a much lower cost than housing and inpatient treatment. And the patient always has, through their mobile device, always has that counselor, that provider as a resource. So now instead of, say that they're paying $300 a month, obviously, you span that over a year and you're talking about $3,600 as opposed to paying $90,000 to $120,000. So the savings, I think, are going to be pretty significant as we drive up the rate of recovery.
Awesome. A follow-up question to that is, given that it's pretty compelling from an economic standpoint, this should be something that both providers and insurance companies should be jumping on right away, right? At least it feels like that. Is there some risk associated with this that would cause the insurance companies to kind of play a wait and see?
No, I don't believe so at all, because with the passage of the Affordable Care Act, it mandates across all healthcare, both acute and behavioral, that we must move to value-based care. And in value-based care, we have to use data to deliver evidence-based outcomes. And so as a whole, already 30 to 40% of Medicaid payments are starting to go in that direction for acute care. Behavioral health is a little bit behind, but we're seeing that whole transition by 2018. So really there's incentive for them to go, because, and it's been our experience, the payers, insurance companies, and providers that we're working with are really kind of thought leaders. They're looking at this as an opportunity to improve the rate of recovery and the quality of services that they're delivering, and at the same time help drive down overall costs and be able to treat some of those 23 million people that aren't getting treatment because they don't have access or can't afford it. So I think there's, the risks are minimal, and the market is really compelling. The market forces are compelling a movement to value-based care and value-based payments.
Got it. And then just looking ahead for a little, do you see other technologies that are coming down the road to improve the treatment and recovery process?
I do, and I think it's really the combination of some existing technology, and then there'll be some new stuff as well, as like Google continues to come up with some pretty creative technologies. But just coming off the shelf, just the introduction of biometric feedback combined with geographic information and behavioral and patient feedback. So now we have 3 or 4 different sets of data coming in, and that's where we would like to partnering with Google on Google BigQuery to be able to do some dynamic real-time situation analysis, so that providers and counselors can provide interventions and help structure the proper intervention based on on these different feedbacks. So just introducing biometric feedback, and then virtual reality, there's a lot of work going on in that space. It's still fairly early, but I think we're going to see that in terms of impacting behavioral health. There's some universities that are doing some pretty interesting work around trying to simulate either soothing situations to help someone calm down, but then also situations that would cause a person to trigger on their substance use disorder, and to help them work through that combined with biometrics, and I think those are some real promising areas.
Okay. We also have a question for you from the audience, and the question is, can you talk about the issue of whether addiction should be treated as a disease, and whether that impacts the solution you're discussing?
Okay. I think that addiction classified as a disease for a couple of decades now. However, there is a stigma associated with it, and oftentimes it's around people think that that's a moral failing or a character flaw, and science has proven that there are definitely issues, in particularly individuals that have continued to abuse substances, that it transforms their brain into a way that they can't generally have a very, very difficult time escaping it. So I don't think that that's a contention. I think it's what we're seeing is a transformation in the marketplace away from the stigma and more people accepting it. Unfortunately, we have way too many deaths as a result of addiction every year, and we need to move beyond the stigma and start treating it as a disease and helping people get through it.
Great. One last question for you. When you started looking at the solution and you decided you were going to do an application, how did you approach doing this app? For example, what were some of your goals? Was it time to market? Was it a lean, agile development cycle? What process did you use? What alternatives did you look at? Can you talk about that and kind of lead into how the choices you made with Kinvey and Google helped you through that process in terms of looking at the alternatives?
Sure. Yeah, we a little bit of a learning process. We're definitely a lean organization focused on agile methodologies. We are self-funded, and so of course we're really watching our budget. And what we did is we got a couple false starts. We went with some development firms that just really wanted to build everything from the ground up, and based on my research, I knew that we didn't have to go that way today, and besides, I wanted to focus on proving the concept first, that what we were talking about doing is really going to add value, and then just keep things as lean as possible and get to market quickly. That was the other driver. That was there's a lot of people creating apps. We're creating a platform, but we still have that to combat the marketplace. So I obviously had researched the mBaaS marketplace and talked to pretty much every vendor and got pretty close with them on terms of what they offered and what their pricing was. And I really felt confident that Kinvey could give us what we needed. And the management team there was very helpful and helped us get this stood up very quickly. And I was very happy to find that you guys were partnered with Google and that we would be HIPAA compliant out of the box, which is another one of our requirements that we would not have met if we'd gone another route. So I think it was just almost like the perfect storm of things that had to happen that we were able to get this stood up and into beta and now piloting as quickly as we could with you guys.
Awesome. Thank you.
I have a question, if I can, for Joe, around BigQuery and healthcare, and I like talk about that wheel with the different functional areas. How does he see that playing out from a Google standpoint in terms of individualized care all the way across into population health?
Sure. I'd be happy to talk about that. So, we're actually really excited to see BigQuery get used in this space. And, there are a wide variety of use cases that BigQuery can address in the healthcare space. We've for those not familiar, BigQuery is a tool that we've developed which allows you to search and analyze extraordinarily large data sets in just the order of seconds. So there we have a lot of examples where we're looking at genomic data that's been stored in BigQuery and cross-linked with human methylation data from other sets, and it allows you to be able to interrogate this data in real time. So you can develop your SQL query and get the answer back in just an order of seconds. And where we see, we have an example where this was done to look at 3 billion rows, answer back in just about a second. And what that does is that dramatically changes the type of interactions that people can have with data. Especially in the healthcare research space, many of these questions were, you'd put together, you'd have a question, and you'd put together a team of people to go investigate that, pore over the data, ingest it. And now much of this has been transformed into an iterative process where you could ask that question, get your answer back basically in real time, and look at the insights you get from that, and then tweak the question and keep asking. And so it really empowers a new type of interrogation of the data. And so we see it a lot in genomics. People using this, and it's been used a lot in when people are looking at thousands of data sets of doing quality control, actually, and looking at how does the data match up with, like, the genotypic data match up with the phenotypic data? How does it align across very other things? If people want to play with it, they're actually, if you go to the BigQuery website, we have a public data. We have a lot of public data placed there as well. And recently we added disease surveillance data from the CDC, so you can go in and look at. It basically has details around the 8 vaccine preventable diseases and their incidence rates all the way back to like the late 1920s. So it's a really interesting way to play with this data. And I see, I imagine we're going to get a lot of use of this in the population health space as well.
Great, thank you. And Jaku, I know one of the real values we had was being HIPAA compliant out of the box. How did you guys get that set up so that so quickly, and so that your clients don't have to worry about that?
Absolutely, Sean. So one of the things that we had to do is to look at the HIPAA compliance has something called the high-tech security rule that provides service providers like us with some guidelines on a set of safeguards that we have to implement, and these include physical safeguards, administrative, where we have to protect all the equipment that we use and run some of our services on, which obviously we rely on the Google Cloud platform and all of the physical safeguards that they have put in place. We also have to have in place administrative safeguards for our people, anyone that is handling any kind of EPHI or electronic health information, private health information, personal health information data, that they would have to be trained on how to handle that data. So there's a bunch of administrative safeguards around that. Technical safeguards, for example, how we encrypt data, how we manage the encryption keys, and there are some specific guidelines around that. How ensuring that the data is encrypted both at rest and in flight and during processing. Being able to have safeguards around notifying our customers, whoever the certified entities are as part of HIPAA, need to be notified if there is any breach. Anytime data is potentially has been breached and there is a vulnerability, we have to make sure that we have reporting in place. And overall, we need a lot of policies and procedures that describe all of this and be able to verify that we are following these policies and procedures and have evidence that we are following these policies and procedures. So it's a fairly long, drawn-out process that we had to go through to complete this assessment. And related to this question also is an audience question that I just got on how we are handling user privacy, especially as it relates to HIPAA. Like I mentioned, we have a privacy policy, a Kinvey privacy policy that is online at kinvey.com that you can go check it out. We have documentation around how we protect user privacy, and anything we do, our data is always anonymized, and we make sure even for our own internal use, for our own internal troubleshooting, that we never provide our people with access to personal information. And it's always protected, encrypted, and that was another question I got from the audience as well, is one around, do we store data on the device? Yes, we do. And again, all of the data on the device is encrypted using the strongest encryption that passes muster, not just with HIPAA, but also with federal security guidelines. So we use AES 256-bit encryption and make sure that the key management is that the encryption keys are managed according to the guidelines specified in the HIPAA security rule.
Great, thanks.
Okay. Anything that you can add in terms of compliance, Joe, for from a Google Cloud Platform perspective, to add to what I just mentioned as well?
Sure. No, I'm happy to talk about that. So yeah, the Google Cloud Platform, we are happy to work with HIPAA-covered entities and their HIPAA-related workflows. We do this by signing a BAA with parties who want to handle identified patient data on the cloud platform, and that's an agreement we've made with Kinvey, and we can make with other HIPAA-covered entities as well. Some of the things that are a bit unique about this is that for our HIPAA compliance story, we actually do compliance at the product level as opposed to the infrastructure level. So that way you can use, so when you're looking at our compute offering, so Google Compute Engine, our BAA covers the entire product offering, which means that you can use any resource type that's available as part of that. So you can use, in any region. You're not limited to a specific data center. You're not limited to specific zones or locations. And you can use preemptible VMs, ones that can be turned off, sort of at will, to get a better price. So that's something that we've done, which is a little bit different than some of the others, because many other vendors, their compliance story is very much based around running their services within a very dedicated infrastructure environment, and we've gone up a step to look at the product level as opposed to just the infrastructure. Yeah, I think that about covers it. I mean, we also don't charge anything extra. Because we don't do this at the infrastructure, because we're not segregating and separating a separate set of infrastructure, there's no additional overhead to us that we then have to pass on to customers through fees with the BAA.
Okay. So I think that that's all the questions that we had. So I just want to thank everybody for joining. Thank you, Jaku, Joe, and Sean for that great discussion. Like I said, we're recording this, so we'll send everybody a recording tomorrow. And again, thanks for joining.